Hello everyone, I will talk about bone defects in instabilities. As the severity of trauma increases, we may begin to encounter bone defects in instability, such as in glenoid or humerus or both of them. Glenoid defects are generally responsible for mid-range instabilities that occur even in during activities, daily activities. On the other hand, the humeral side defects are responsible for the end-range instability that we see at the extreme limits. When we look at the prevalences, we see that the glenoid bone defects occurs 20% of first dislocations, and it can be occur up to 90% in recurrences. On the other hand, the Hill-Sachs deformity can be seen up to 65% even in first dislocations. We generally see four types of glenoid bone losses. Acute chronic cases where the fragment can be present and can be reduced, and the chronic cases with bone losses that we cannot reduce or fix. Sorry. Videonun oynamasını oradan mı yapacağız? Şöyle geri döneceğim. We evaluate the Hill-Sachs deformity according to its size and the borders of the lesion with some measurements that we will talk a bit later. What's the clinical importance of these bone defects? When we look at the lower study, we see that there is a significant increase in recurrences with large bone defects comparing to small ones. Again, in the study conducted by Shaha, we observed that recurrence increases significantly when the glenoid bone loss exceeds the 20%. In this context, if we encounter an acute or chronic instability case with a bone fragment in glenoid, we have to fix them to ensure the ideal stability. Depending on its size, we can see small ones, medium ones, or large bone defects. In acute cases, there is no resorption and there will no union phase, and therefore mobilization and anatomical fixation will be relatively easy, as you see in the video. But in chronic cases, there will be a union phase and resorption, so that mobilization will be difficult. Bone losses may occur while trying to mobilize the fragment, and anatomical fixation may not be possible. In small, medium fragments, we can use suture anchors. It will be sufficient. The anchor placed at the edge of the cartilage, we pass the suture passer through the labrum and capsule as if we do a classic Bankart repair. The fragment will be reduced when we reduce the labrum, so that we can use Prolen as a carrier thread. We see there when the labrum reduced, the fragment comes to reduce. In the presence of a large-sized bone fragment, the suture anchor is placed under the joint. The suture passer passed under the fragment or transversely, and because of that, we have to use metal carrier because the tip of the carrier can be blocked by the bone fragments. While trying to reduce, we can support the fragment with a probe or rasp, and we have to consider the fragment size. We may have to use second or third anchors to reduce the fragment ideally. We're passing the thread, you see, a metal carrier. We're passing the sutures. And we see the reduced fragment. When we look at the results of the treatments performed with this technique, we see that the recurrence rates and outcomes are similar to those who has not bone defects. And in the studies conducted at on contact athletes, we see again the results and recurrence rates are similar to those who has not bone defects. But they say it is critical to reduce the glenoid defect rate below 5%. And if not, the recurrence rates increases significantly. In chronic cases, when the fragment is resorbed, the size of defect becomes important, and we determine how to treat these cases with some measurements. Itoi conducted a biomechanical study in 2007 on cadavers. The shoulder was examined in maximal external rotation and in various degrees of abduction. They observed the contact surface relationship between the glenoid and humeral head. And as a result, as we see in the figure, a contact surface map appeared. It goes from inframedial to superolateral with increasing the abduction degrees. And they named this contact surface map as glenoid track. They determined that the distance of this track from the footprint of the medial rotator cuff to the end of the medial side to cartilage corresponds to 84% of the maximal glenoid width. And as a result, they stated that if a Hill-Sachs lesion's borders doesn't exceed the end of the medial cartilage, the lesion will be on track and the only labral repair will be sufficient. But if a Hill-Sachs lesion exceeds this medial border, then it will be named as off-track lesion and only labral repair will not be enough to treat this instability. Sorry. Later, Burkhardt updated this ratio to 83% by studying on live shoulders and evaluating the dynamic factors. And in this example, first we calculate the maximal glenoid width, then calculate the 83% of this and find the glenoid track, then apply it to humerus from the medial footprint of rotator cuff to the medial end of the cartilage. Then we look at the Hill-Sachs lesion, and we see, as in the example, the Hill-Sachs lesion lays in the borders, so we call it an on-track lesion, and only labral repair will be sufficient, as we see in the animation. Firstly, humeral head engages to glenoid anterior rim, but after a labral repair, it will not engage anymore. In cases where the Hill-Sachs exceeds the medial border, then we name it off-track lesion. And as we see in the animation, only labral repair will not be sufficient, and humeral head continues to engage to glenoid anterior rim. We see like this. Burkhardt states that there is no significant difference between our two glenoids in our shoulders. So if we have a defective glenoid, we can use the healthy glenoid to calculate the glenoid track. At first, we find the maximal glenoid width from the healthy glenoid, then takes its 83%, and we find the ideal glenoid track. After that, we have to subtract the defect size from the ideal track. And then we will find the real glenoid track length of the defective glenoid. And as in the figure we see, at first the G2 line is the ideal track length, but after the subtracting the defect size, we find the G1, the real track length. After that, we look at the Hill-Sachs lesion and we see there is an off track. So we have to do something more than labral repair. And when we look at the animation, Normally, it's an on-track lesion. The blue marked area is the glenoid track length. Normally, it's an on-track lesion, but if we have a glenoid defect, then the lesion becomes off-track. Another method used to diagnose is dynamic assessment. Some say that it can be checked whether the heel sulcus is engaged to glenoid anterior limb in arthroscopy before Bankart repair. However, theoretically, if there is a heel sulcus, it means that is already engaged to the rim with the present instability. What we look for with measurements and examination is which treatment will get rid of this engagement. Therefore, in our opinion, there is no point in looking arthroscopically before the repair. In addition, disengagement control can be done with dynamic evaluation after the Bankart repair. However, it's mentioned that the possibility of the straining the repair too early may be harmful. And besides, studies have shown that the glenoid tract evaluation made with pre-surgical measurements are highly similar with the dynamic evaluation after the Bankart repair. So exactly, we don't have to control it after the repair if we have done the measurements. So, which procedure should we apply to whom? First, we look at the glenoid. If the glenoid defect is smaller than 25%, then we do labral repair. If it's larger than 25, then we have to do something more like bone procedures, Latarjet or bone block surgery. Then we look to humerus. If it's on track, no addition needed. But if the case is off track, then we have to intervene to humerus, such as remplissage or grafting in larger cases. In remplissage, we compress the infraspinatus to the defect. We place an anchor into the defect, then pass the threads from infraspinatus and tie them from subacromial space. We usually place the anchor and pass the threads from infraspinatus before Bankart repair, but leave the tying knots after the repair because of the visualization quality. Seeing we are passing the threads from infraspinatus, and when we tie them, infraspinatus fills the defect and ensures the stability. In arthroscopic Latarjet, we dissect the coracoid first, then we open two holes in the coracoid with special guides and cut the coracoid. Then we pass it through subscapularis and we fix it with screws to the edge of the glenoid. Now we are passing it from subscapularis. Then we are fixing it. And as a result, we see the largened glenoid. Or we can perform bone block surgery using grafts that we can take from various places. In this case, we are seeing a large defective glenoid. We have some special instruments for this, some large cannulas, some endobaton device, and some specialized anchors to do this surgery. We are preparing the graft, two-side cortical. We put the endobaton on. We put the endobaton from the cortical side. Then we have to make a tunnel to pass the block in. We have a specialized guide to put the anchors in. After that, we have to match the holes with these anchors in the graft. Now we are putting in. And we are matching the holes. These anchors are specialized to increase the stability. Then we are tying the knots. After that, we will do a Bankart surgery too. We put the anchors at the edge of the cartilage, then tie the labrum onto it, and increase the stability a bit more. When we look at the studies, the Latarjet and the bone block surgery have similar results. In conclusion, while anatomic repair is sufficient for labral repairs, labral lesions, we need to keep in mind the non-anatomical repairs and bone procedures in bone defect with careful measurements. Thank you.